Hello, it's Dmitry again. Today we'll be going back to and I will always want to say this correctly, so I will try to say it correctly now. We're in the first aid for the Step 2 CK textbook for the algorithms version of the book. I was just phrasing like that. If you're looking at the video title right now, you know what I'm talking about. And we've done 2 videos on this thus far. Well, technically 3 videos. We've done one as an introduction, and then we've done 2 cardio videos. This is another cardio video. There'll probably be 4 total. And so we'll do another maybe hour and a half this time around as well. So Chapter 1, Internal Medicine, Cardiology, Part 3. So we're on page 27 right now. Adult cardiac arrest, VF, PVT, asystole, PEA, ACLS protocol. So I don't know what that means. Just going to tell you up front. I don't know what those acronyms mean necessarily. Maybe I might be able to pull off 1 or 2. Maybe. Probably not, actually. I'm not sure. Let me just see what they mean. So what do these mean? So VFib, ventricular fibrillation. Okay. PVT, pulseless ventricular tachycardia. Okay. Asystole. Okay. And what's the PEA? PEA is pulseless electrical activity. Yeah, okay. That's fine. So, cardiac arrest in an adult. What do? Give O2, attach defibrillator, cardiac monitor, pulse ox. Shockable syndrome, if it is positive for that, well then, let's go for if it's negative. If it's negative, it's PEA. Again, that's pulseless electrical, what was it? Pulseless electrical activity. Okay. So if it's negative for shockable syndrome, then it's pulseless electrical activity, asystole, in which case CPR for 2 minutes, IV/IO access, give epinephrine ASAP, then every 3 to 5 minutes, airway access, consider advanced airway capnography. As I'll note here, it says here, advanced airway, endotracheal ET intubation, supraglottic advanced airway, and then 2 for capnography. Waveform capnography or capnometry, to confirm the monitor ET2 placement. To confirm and monitor the ET2 placement. Okay. Next one, shockable syndrome. We're asking the same question basically. If it's still negative, then CPR for 2 minutes, treat reversible causes. Reversible causes include hypovolemia, hypoxia, hydrogen ions, acidosis, hypo/hyperkalemia, hypothermia, tension pneumothorax, tamponade, cardiac, toxins, thrombosis, pulmonary or coronary. What about it's positive? Now it's shockable. What do? See step 4. Okay, so we'll go to that if we need to. So let's go back to this earlier part. So we cardiac arrest in an adult, we give the oxygen, so forth. Is it shockable? If it's shockable, then VFib, pulseless V tachycardia, ventricular tachycardia. So what do you do in that case? Shock, IVIO, obtain access, CPR for 2 minutes. Then you do the thing again, shockable syndrome. If it's not shockable, if no signs of ROSC, 4, go to the step 2. So what is 4? Return of spontaneous circulation. If there are no signs of return of spontaneous circulation, then you go to step 2, which is what we were talking about before with the under PEA over asystole, right? Go back to step 2. If there is a return upon spontaneous circulation, then post-arrest care. Okay, in which case you go, here's a little 5 thing. Here says post-cardiac arrest care, optimization of ventilation and oxygenation, avoid hyperventilation, treatment of hypotension with IV fluids and vasopressors as needed, epinephrine, norepinephrine, dopamine, evaluation and treatment of cause, that is to say emergent cardiac intervention for MI or unstable cardiogenic shock, targeted temperature management, 32 to 36 degrees Celsius for 24 hours, and neuroprognostication, EEG, CT of head. If unable to follow commands and other critical care management, PEA equals pulseless electrical activity, VFib is VFib, and VTAC is VTAC, ventricular tachycardia. Okay. Anyway, back to this. So let's say it was shockable syndrome, and it was shockable again, then you do a shock. CPR for 2 minutes, give epinephrine ASAP, then every 3 to 5 minutes, consider advanced airway capnography. Is it shockable again? If it's not, then you go back to the if no ROSC, blah, 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 blah. If it is shockable, then you shock again. This is a third shock, I guess. CPR for 2 minutes, give amiodarone or lidocaine, treat reversible causes. Okay, what about adult bradyarrhythmia, ACLS protocol? If bradyarrhythmia less than 50 BPM, identify and treat etiology. Again, here's the etiology right here. Potential causes, electrolyte abnormalities, severe hyperkalemia, toxicologic medication induced, for example, beta blockers, calcium channel blockers, myocardial infarction. Cardiac monitor BP, obtain IV access, oxygen if hypoxemic, maintain airway, 12-lead EKG. Indications for atropine, signs of shock, altered mental status, chest pain, hypotension, acute heart failure. Okay. If it's negative, well, in that case, continue to monitor. If it's positive, well, then you do atropine, right? If ineffective, transcutaneous pacing or epinephrine infusion. From there, you consider transvenous pacing. And so really the goal today is either to get through about an hour and a half of it, or let's see, 25. Okay, so maybe we get to page 37-ish, maybe 40, maybe 35, somewhere between 10 to 20 pages, and then just kind of wrap up and finish. And get the last little block for our final video, presumably. We're on 29 right now. Adult, well, if I did 30, that'd be too short. But let's see what we can do. 115, adult tachyarrhythmia with pulse, ACLS protocol. Persistent tachyarrhythmia greater than 150 BPM with a pulse. Evaluate and treat underlying cause, secure airway, give O2 if hypoxemic, pulse oximeter, EKG. Indications for cardioversion. Cardioversion here says hypotension, signs of end organ dysfunction, chest pain, heart failure, altered mental status. So what are indications for cardioversion? If it's negative, then wide QRS greater than 0.12. If that's negative for that too, well, then IV access, vagal maneuvers, and adenosine if regular rhythm, beta blockers or calcium channel blockers. Okay, what if it's positive? In that case, IV access, consider adenosine, IV antiarrhythmic. And for the antiarrhythmic, they say procainamide, amiodarone, sotalol. They also say if refractory to the above measures, consider addition of an antiarrhythmic agent, elevation in energy level for the next cardioversion, and evaluation and treatment of any potential underlying causes. Let's go back to indications of cardioversion. Let's say we have indication of cardioversion. They are present. They're positive. In that case, you do synchronized cardioversion. Neurocomplex tachycardia. In that case, do consider adenosine for treatment. And there's a 4 there again. It says again, if refractory to the above measures, we consider additional of antiarrhythmic agent, elevation in energy level for the level of next cardioversion, etc. Right? And treatment of any underlying potential causes. So here's one that's a little bit more complicated. It looks a little more serious, doesn't it? We're on page 30 now, and this is pages to the side. So it doesn't fit all in my shot. I guess I could probably expand if I wanted to. There we go. Now I can't read it. Now you can't read anything, can you? And it doesn't even necessarily show all of it. Let me see if I can. Huh. How about that? Take a picture if you want to. Whatever. Or you can find the book maybe. Let's see if we can do this. Can you see it now? I guess you can see everything, but it's probably not very big. So let's just go back up. So we have here palpitations, syncope, fatigue. So that could be, I guess, a number of different things. And so we have to do an EKG. Let's say, for example, the EKG shows an atrial origin. In that case, let's say P before every QRS, heart rate is less than 60. What do we think? Sinus bradycardia. In that case, we do troponins, inferior MI, medication review, calcium channel blocker, beta blocker, TSH, hypothyroidism. In which case, asymptomatic and... Well, let me continue with this stuff. Okay. So let's say palpitations, EKG. EKG can indicate an atrial origin, AV origin, or his Purkinje conduction. If we say atrial origin, in that case we can think about the P before every QRS heart rate is less than 60, then we think sinus bradycardia. If we think the transient absence of P waves of greater than 3 seconds, we think sinus pause/arrest. If we're thinking tachyarrhythmia, AFib, flutter, etc. with abnormal SA AV conduction, then think about tachy-Brady syndrome. So let's talk about sinus bradycardia or sinus pause arrest as we were talking about before. In both cases, we're thinking troponins, inferior MI, medication review, calcium channel blocker, beta blocker, TSH, hypothyroidism, in which case asymptomatic and hemodynamically stable, in which case you do treat the underlying cause, MI, thyroid disease, infections. If we're thinking, for example, symptomatic or hemodynamic instability, in which case ACLS protocol, atropine, transvenous pacemaker, or we're thinking pauses greater than 3 seconds of heart rate or heart rate less than 40, in which case you do a permanent pacemaker. Let's say, for example, we're talking about before, we said troponins, inferior MI, medications review, so forth, and we say no other reversible causes, in which case we have 6 sinus syndrome, in which case permanent pacemaker. We're talking before about tachyarrhythmia, AFib, aflutter, etc. with abnormal SA AV conduction, in which case you have tachy-Brady syndrome, in which case what do? Permanent pacemaker. What about something with an AV origin? Well, in that case, it could be if it's a PR greater than 200 milliseconds, I think. Yeah, greater than 200 milliseconds. First degree AV block, first degree block. Well, no, it is first degree. I would say first degree AV block, but I say first degree block. Okay. What about if it was intermittent P waves not followed by a QRS, in which case second degree AV block? What about a complete absence of conducted P waves, AV dissociation, in which case it's a third degree AV block? So in a first degree AV block, you do Lyme titers, infiltrative heart disease, medication review, beta blockers, calcium channel blockers. If it's negative for that, well, then no treatment's required. If it's positive, treat underlying cause, MI, thyroid disease, medications, infections. What about if you had a secondary AV block, in which case you do medication review, digoxin, calcium channel blockers, beta blockers, troponins, right MI. If you have progressively elevated PR interval until a dropped beat, in that case it's called Mobitz type 1 or Vankebach. If you have it where it's a constant PR interval beats, PR interval contains drop beats about 2 equals 2 pp intervals. Basically what they're saying is that there's occasionally drop beats, but there's no change in the value of the actual PR interval. It stays the same. That's called a Mobitz type 2. Now that's more pathological than Mobitz type 1. Mobitz type 1 where it's actually increasingly getting wider and wider until stopping, and then it resets basically. That's more likely to be physiological and not dangerous to the person. So if Mobitz type 1 we're talking about before was asymptomatic, where you treat underlying cause, MI, thyroid disease, medications, infections. If it's symptomatic, you have symptoms of palpitations or syncope, in that case you do a permanent pacemaker. Well, so let's say, for example, we go to Mobitz type 2. Mobitz type 2 is the one that's more likely pathological, where it just randomly drops, or it drops the P, but it doesn't actually explain why. There's constant PR intervals, but the R interval contains drop beat. Yeah, the drop beats just happen. They probably happen they might happen in a pattern, I guess, I would assume. But they have no progression to wider and wider PR intervals before it actually happens. That's more likely to be pathological Mobitz type 2, in which case you do, again, a permanent pacemaker. What if I had a third degree AV block we were talking about before, in which case you also do a permanent pacemaker? Okay, let's go back to EKG. Let's say the EKG showed a his Purkinje conduction abnormality, in which case you might just have to, say it with me, if you have an alternating bundle branch block, you just do a permanent pacemaker. Alternatively, if you have a QRS greater than 120 milliseconds and the positive right in I, AVL, and V6 is probably a left bundle branch block, in which case you do ischemic workup, troponin, trend, EKG, MI, they have an MI. If it's positive for that, then it's an MI. C chest, pain, ACS, pages 2 through 5. What about, for example, you had a hyperkinetic conduction abnormality and you had a QRS greater than 120 ms, okay, RSR in a V1, rabbit ears, negative S in V6. In that case, it's a right bundle branch block. What if it's either LBB or RBB? What if it's, say, for example, you have this hyperkinetic conduction abnormality, and let's say you have a left axis deviation plus an upright QRS in I, is that 1? Negative QRS in AVF, I think it's 1. In 1, negative QRS in AVF, normal QRS duration. In that case, it's a left anterior hemiblock. And if let's say you had a left axis deviation plus a negative QRS in 1 and AVL, upright in 2, 3, and AVF, normal QRS duration, the answer would be a left posterior hemiblock. So left anterior and left posterior hemiblocks. In which case, in both cases, you do an RBB plus 1 facile, which will show a bifascicular block. In which case, you have PR prolongation, meaning you're going to have a trifascicular block. So again, it would be bifascicular block, but if you actually have a PR prolongation, it would be a trifascicular block. Well, that was a mouthful. Is this fine? My antler's a little bit in the way, I don't know. Maybe I could keep it, I could probably keep it like that. Okay, let's talk about it. Bradyarrhythmias. So bradyarrhythmias, this is going to be a vignette. A 65-year-old male with a past medical history of coronary artery disease presents with chest pain and hypotension. Exam, he is diaphoretic, bradycardic with heart rate of less than 60 BPM, and hypotensive with a blood pressure of 75/40. Lab/imaging, EKG shows bradycardia with ST elevations in the right leads and ST depressions in the anterior leads. Management, acute inferior MI, revascularization, IV fluids avoid nitroglycerin. AV block, first degree and type 1 second degree, observation of asymptomatic. Okay, and I assume this is the rest of it right here. Type 2, second degree and third degree, complete heart block, permanent pacemaker. Well, yeah, third degree is complete heart block. Type 2 is obviously not. But in those cases, you go for a pacemaker. Unless it's Mobitz type 1, in which case you might not necessarily need a pacemaker, but you might still want to. If symptomatic, atropine, pacemaker. All hemodynamically unstable patients, ACLS protocol, atropine, dopamine, epinephrine, emergent transcutaneous pacing to stabilize the patient, transvenous pacing. Complications, cardiac arrest, syncope. High yield fact, permanent pacing is indicated for symptomatic bradycardia with no underlying reversible cause and in asymptomatic patients who have an AV and infranodal conduction disturbances that have a high risk for progression to complete heart block or asystole. So sinus rhythm with first degree AV block, right here. This is a second degree AV block, Mobitz type 1 AV block with Brinker-Bach phenomenon, right? Where you see there's this progression of the pure interval until it disappears, right? So the pure interval gets wider and wider, or I should say it's getting smaller and smaller. I guess it is, yeah, it's getting smaller and smaller. So the interval becomes smaller and smaller and smaller until it just is gone. And then Mobitz type 2, right here, there's no change. It's just randomly, there's a gap and that's it. There's no trend going on that resets itself, like in Mobitz type 1. And then you have right here, complete third degree AV block. This is where the QRS complex has nothing to do with the P waves at all. They're completely unrelated to each other. You might have for example, in this case, the number of it can count the QRS block between the QRS complexes. So let's say, for example, 1, 2, 3, 4, 5, 6, about 6. Or right here, 1, 2, 3, 4, 5, 6, about 6. So the QRS complexes are evenly spaced. And the P waves are probably evenly spaced too, but the amount of spaces between each is not going to be the consistent because they're basically having two independent pacemakers, effectively speaking. Which is very weird, but that indicates a third degree AV block because they're just not connected anymore. So here's another graph for us right here. This is called supraventricular tachyarrhythmias. heart rate greater than 110, QRS is less than 120 milliseconds, supraventricular tachycardia. What we do is an EKG. An EKG will either show a regular rhythm or an irregular rhythm, different RR interval. Fair enough. If it's a regular rhythm, and the P wave is before the QRS preceded by a P wave morphology, 1, 2, 3, sorry, 1, this is like plus 1, 2 AVF. It might be an error on their part. They put 2 twice, but whatever. It might be 1, 2, 3 AVF, not sure. In that case, what we want to do is check for physiologic stimulus, pain, hypovolemia, anemia, sepsis, plus or minus. If it's positive for that stuff, it's appropriate sinus tachycardia. You do treat underlying cause. If it's negative for that, then it's inappropriate sinus tachycardia, in which case TSH, urine, metanephrines, and catecholamines. In which case, TSH is going to be decreased. If TSH is decreased, it's hyperthyroidism. If it is 2 times elevation in urine, metanephrines, and catecholamines, in that case it's pheochromocytoma. In both cases, see endocrinology chapter page 131 for treatment and further workup. Okay. If you have, let's say for example, you have regular rhythm, but you have a P wave fused with QRS complex, pseudo R V1 or pseudo S 2,3 AVF, in which case it's a typical AV-NRT, which is also called, according to this, a AV nodal reentrant tachycardia. Also, where's the 1 located? The 1 is appropriate sinus tachycardia, in which case, if hypoxia or dyspnea, consider PE. And the 2 is somewhere, I'd assume. I don't know where the 2 is, but somewhere. Anyway, so that's typical AV-NRT. In the other case, let's say you have a short PR delta wave, short PR delta waves present. You will have an AVRT, which is a atrioventricular reentrant tachycardia. So in that case, we'll go into the typical AV-NRT again. AV-NRT. Again, AV-NRT is going to be the AV nodal reentrant tachycardia. In which case, again, it goes back into the whole thing we were talking about before with the inappropriate sinus tachycardia, TSH, urine, metanephrines, and catecholamines. And then you go down to lower TSH for hyperthyroidism, or you have the metanephrines and so forth for pheochromocytoma. And we're thinking about AVRT, which again is the atrioventricular reentrant tachycardia. Well, then we're thinking about hemodynamic stability. If that's positive for that, then we're thinking symptomatic tachycardia. Then we're thinking about Wolff-Parkinson-White syndrome. I knew that off the top of my head, I think 9, yeah, WPW. If it's narrow complex, then it's orthodromic, in which case you'd use adenosine, vagal maneuvers, beta blockers, calcium channel blockers. Similar thing where you do a typical AV-NRT. If you have hemodynamic stability, it's positive for that, then you go for the same things, adenosine, vagal maneuvers, etc. If the Wolff-Parkinson-White has a wide complex, though, then it's antidromic, in which case you use procainamide for it. And the way you can remember that is procainamide, procaine like canine, and Wolff-Parkinson-White like a wolf. So a wolf is a canine, okay? Hopefully that helps. Let's say we're talking about irregular stuff now. Let's talk about irregular stuff. So irregular rhythm and different RR interval. Let's say it's greater than 2 P wave morphologies, in which case it's MAT. MAT referring to multifocal atrial tachycardia, in which case if there's hemodynamic stability, do beta blockers or calcium channel blockers. Let's say, for example, we have flutter waves, ventricular rate is greater than 150, in which case it's A flutter, atrial flutter, with variable AV block. Or let's say, for example, we have a regular baseline and no P waves, in which case it's AFib, atrial fibrillation, in which case both for A flutter and AFib, you do anticoagulation. If there's hemodynamic stability, in that case, do beta blockers or calcium channel blockers. What about if you have P waves comes from earlier PP interval, P waves with different morphology or axis, in which case it's going to be PAC, which is going to be premature atrial contraction, in which case no treatment is necessary. So supraventricular tachyarrhythmias. This is probably going to be a mouthful in my opinion. So supraventricular tachycardia, SVT, arises in the atria or AV junction. Paroxysmal supraventricular tachycardia, PSVT, usually arises in patients who are young with healthy hearts and is often caused by abnormal reentry pathways, AVNRT, AVRT. EKG shows normal QRS. SVTs also include AFib, atrial flutter, and multifocal atrial tachycardia. EKG shows irregular QRS. Sinus tachycardia, appropriate and not appropriate. So here's a vignette. A 34-year-old female with no past medical history with nausea, right flank pain, dysuria, and fever, exam tachycardia greater than 100, blood pressure of 90/65, temperature of 101.1, and the costovertebral ankle tenderness on the right. Labs imaging, CBC of leukocytosis, UA with many bacteria, pyuria, hematuria, urine culture positive for E. coli, EKG with normal sinus rhythm and tachycardia. Management. If appropriate, treat underlying cause that triggers this physiologic tachycardic response, that is to say, if sepsis, give fluids and start antibiotics. If inappropriate, beta blockers, calcium channel blocker. Complications, depending on the underlying cause, can lead to hemodynamic instability and shock. High yield fact, if unclear physiologic trigger, consider the inappropriate sinus tachycardia. This should always be a diagnosis of exclusion. What about premature atrial contraction, or PAC? A 30-year-old female with a history of sudden cardiac death presents to primary care clinic to establish care. She denies any symptoms. Exams, vitals show a complete physical exam are normal. Vital signs and complete physical exam are normal. Labs and imaging, EKG shows a P wave followed by normal QRS complex with a different PP interval shorter than previous interval. How do you manage it? Premature atrial contraction. If it's asymptomatic, no intervention is needed. However, if it's symptomatic, consider a beta blocker. Complications, very rare, AFib, ischemic stroke. High yield fact, isolated premature atrial contractions without premature ventricular complexes are not associated with increased risk of sudden cardiac death. What about atrioventricular nodal reentry tachycardia, or AVNRT, atrioventricular reentrant tachycardia, AVRT? A 30-year-old female with no past medical history presents with palpitations or syncope, mostly when exercising. Exam, tachycardia greater than 100, blood pressure 100/65, labs, imaging, EKG with narrow complex tachycardia, normal QRS. The management, if unstable, cardioversion. If stable, consider vagal maneuvers like Valsalva, carotid massage. Also consider IV adenosine. So we're continuing with this. Again, this is all about the atrioventricular nodal reentry tachycardia, or AVNRT. In which case, for long-term control, consider AV nodal blockade, like beta blockers or calcium channel blockers, or catheter ablation of accessory conduction pathway. Of note is that if there is a concern that AVRT is due to rapid AFib in patient with Wolff-Parkinson-White, avoid beta blocker and calcium channel blocker. Complications, tachycardia-induced cardiomyopathy. High yield fact, AVNRT is due to the presence of both slow and fast conduction pathways in the AV node, creating a reentry circuit in the AV node that depolarizes the atrium and ventricles almost simultaneously. On EKG, the P wave is hidden in the QRS or seen shortly after. It is most important as It is the most common supraventricular tachycardia and presents commonly in patients 30s and 40s, female greater than male. AVRT is due to the separate accessory conduction pathway between the atrium and the ventricle that causes a reentry circuit. On EKG, a retrograde P wave is often seen after a normal QRS seen in Wolff-Parkinson-White, which is below. Multifocal atrial tachycardia, or MAT. An 80-year-old male with a past medical history of COPD presents with palpitations, dizziness, and chest pain. Exam, heart rate is 135 and irregular, SpO2 of 86%. Lab/imaging, EKG shows an irregular rhythm with greater than 3 different P-wave morphologies that have irregular intervals. Management, treat with inciting disease. electrolyte repletion for hypomagnesemia or hypokalemia, calcium channel blockers, verapamil, diltiazem, are often first line. If no concurrent heart failure or bronchospasm, can use beta blockers, metoprolol. High-yield fact about multifocal atrial tachycardia. MAT is associated strongly with pulmonary disease, most often COPD. Renal failure, hypomagnesemia, and hypokalemia are also common contributing factors, with the pathophysiology remaining unclear. It is thought to be related to the right atrial distension from pulmonary hypertension, leading to multiple competing sites of atrial activity. Oh, there's definitely a part. There's a whole part too. Wow. What about AFib, atrial fibrillation? A 65-year-old female with a past medical history of obstructive sleep apnea and alcohol use disorder presents with palpitations and dizziness. Exam: heart rate is greater than 100 with a regular pulse, blood pressure is 80/50, lab/imaging, EKG with narrow complex tachycardia and a irregular rhythm with no discernible P waves. Management: if unstable, cardioversion. If stable, rate control with beta blocker, calcium channel blocker, or digoxin. If already on anticoagulation or new onset AF less than 2 days, AFib I guess we would say, less than 2 days, consider chemical amiodarone or electrical cardioversion. If onset is greater than 2 days or unclear duration, obtain a transthoracic transesophageal echocardiogram to rule out presence of atrial thrombus. If there is no thrombus, cardiovert. If the atrial thrombus is seen, start anticoagulation and wait 3 to 4 weeks before cardioversion. Okay, now we're going to continue with supraventricular tachyarrhythmias. Well, this is still all talking about AFib. So this is still talking about AFib right now. Alternative therapies include rhythm control with antiarrhythmics or catheter ablation, or AV node ablation with pacemaker implantation. 6. Anticoagulation for patients with CHADS, is it CHA2DS2 VASC score greater than 2 or more? I've seen it as CHADS2 before. I guess they're saying it as SCHA2DS2, vascular score greater than 2 or more. Complications: tachycardia, induced cardiomyopathy if rapid ventricular response is sustained. Cardioembolic phenomena like stroke or limb ischemia. High-yield fact about VFib, or is this AFib? This is AFib, I believe. Yeah, so high-yield facts about AFib. Usually due to ectopic foci within the pulmonary veins, patients can be asymptomatic or present with dyspnea, chest pain, dizziness, or palpitations. Sustained rapid ventricular response can induce tachycardia-mediated cardiomyopathy, leading to heart failure and cardiogenic shock. Poor atrial contraction can lead to formation of mural thrombi in the left atrium, most commonly the left atrial appendage, which can cause strokes. Etiologies of AFib would be PIRATES, which is an acronym, pulmonary disease, ischemia, rheumatic heart disease, anemia, atrial myxoma, thrombotoxicosis, ethanol, sepsis. Atrial flutter. A 50-year-old female with a past medical history of COPD and mitral valve prolapse presents with 2 days of palpitations and dizziness. Exam: heart rate is 150 BPM, lab/imaging, EKG shows narrow complex tachycardia with sawtooth waves in 2, 3, and AVF. Management of atrial flutter is similar to that of atrial fibrillation. Mainstays of treatment are rate control and anticoagulation for patients with a CHAD, a CHA2DS2 vascular score of 2 or more. Catheter ablation is often the definitive treatment. For inconclusive EKGs, adenosine administration can briefly block AV node conduction and reveal the classic sawtooth wave that will be hiding behind the QRS. Complications of atrial flutter: thromboemboli and heart failure. High-yield facts: atrial flutter is usually a regularly regular rhythm, RRR, regular rate and rhythm. That is to say, consistently rapid rate, unless there is a variable AV block as opposed to that of atrial fibrillation, which is irregularly irregular. EKG will reveal a narrow complex tachycardia of 150 BMP with a sawtooth waves in leads 2, 3, and AVF. Patients often have a history of cardiac or pulmonary disease. So again, And AFib is going to be irregularly irregular. For atrial flutter, it's going to be regular rate and rhythm. What about Wolff-Parkinson-White syndrome? A 20-year-old male with a no past medical history presents with a syncope after playing soccer. He has had no prodromal symptoms. Exam is normal. Lab/imaging show EKG with a slurred upstroke of QRS consistent with a delta wave. How do you manage the Wolff-Parkinson-White? Well, observation for asymptomatic patients, but in a setting of acute irregular tachycardia from atrial fibrillation/flutter in patients with Wolff-Parkinson-White, administer amiodarone or procainamide. Avoid calcium channel blockers or digoxin. Radiofrequency catheter ablation is curative. Complications of WPW, sudden cardiac death, which is rare though. So here's a little diagram right here for you. So high yield fact about WPW. This type of AVRT is caused by an abnormal fast accessory conduction pathway from the atria to the ventricle, bundle of Kent. Delta waves are characteristic. So that's AFib right there. Here's delta waves in Wolff-Parkinson-White syndrome. That's what they look like. And here's atrial flutter with variable block. Here's a multifocal atrial tachycardia, or MAT, with varying P wave morphologies in PP intervals. And here's atrioventricular nodal reentrant tachycardia, or AVNRT. And now we're going to go to ventricular tachyarrhythmias. So we're talking before about atrial. This is supraventricular tachyarrhythmias. So now we're going to be talking about ventricular tachyarrhythmias, but we're on page 35 right now, and we've gone 36 minutes and some seconds and counting and so forth so far. So I'm going to take a break and come back to you. Just skip ahead if you're watching the recording. Okay, I am back. So, let's see. We are on page 35. I'm interested in when this actually ends because I think that the thing ends itself on 51. I won't go that long. Huh, how about that? So this is like page after page after page of this stuff. So maybe we stop on page, these are antiarrhythmic drugs. Okay. This might feel like a detour for you, I'm not sure. So maybe we stop here on page 30, page 36. I guess. I don't know, because I feel like it's so topical. This is all about drugs, so that's page 37. So maybe we just finish up tomorrow on page 37 onward, wrapping up at 51, I believe it is. Is that right? Let's see. We're on 58 right now, technically. We're talking about PDF pages. So this is 47, 48, 49. 51's this last page right here. Is that the actual final page? No, it's not. Wow. Oh, no. Well, I mean, okay. It's on 52, but that's not a big deal. So we're on 52 right now, page 75, I guess in the PDF. And we're page 35 right now. So, I mean, really, it's like 17 pages. So let's just knock down a couple pages and just kind of wrap it up for today. So, ventricular tachyarrhythmias. So now we're talking ventricular tachyarrhythmias. Okay. Let's say, for example, we have palpitations, pre-syncope, or syncope. Vital signs, EKG. If it's hemodynamically unstable, then you do ACLS protocol. What if, though, we have isolated, usually a single wide complex QRS, different morphology than the sinus B, in that case, premature ventricular contractions, or PVC? What about regular monomorphic wide complex tachycardia? In that case, it's VTAC, ventricular tachycardia. What if we have irregularly disorganized rhythm, in which case we have VFib, ventricular fibrillation? What if we have a heart rate of 60 to 100, plus or minus an AV dissociation, a wide complex third degree AV block, and then we have accelerated idioventricular rhythm? So let's go back to PVC, premature ventricular contractions. That's again with the isolated, usually a single wide complex QRS, different morphology than the sinus beat. If it's a PVC, what do? No treatment required. The exceptions are those that are actually symptomatic. Greater than 10% of all beats or PVC-induced cardiomyopathy. So if you actually have like a random PVC and it's not symptomatic, it's not really a problem. But if you're having a lot of PVCs and you're having some symptoms of it, well, then that's an issue. Okay, but what about, let's say, for example, we have a ventricular tachycardia. Again, that's a regular monomorphic wide complex tachycardia. What do we think? If it's non-sustained to less than 30 seconds, or if it's sustained greater than 30 seconds or more, then you do troponin stress test versus angiography to rule out ischemia. Also, if it's greater than 30 seconds or more, then you also have to say ACLS protocol, in which case you do ICD placement, secondary prevention, and it goes back to troponin stress testing versus angiography to rule out ischemia. We'll go into that a little bit later and what that means. What about if it's, again, vital signs? Let's say it was ventricular fibrillation. In that case, where it's a regular disorganized rhythm, in that case you do, again, ACLS protocol, ICD placement, secondary prevention, troponins, stress testing versus angiography to rule out ischemia. The other thing, again, is accelerated idioventricular rhythm. That's because, again, a heart rate of 60 to 100, plus or minus AV dissociation, wide complex third degree AV block. In that case, if it's accelerated idioventricular rhythm, likewise, again, you all do troponin, stress testing versus angiography to rule out the ischemia. Let's say, for example, in any of these cases, right, let's say it's positive. Let's say it's positive. In that case, you do a coronary angiography plus or minus PCI. What if it's negative? Well, if it's negative, what we can do is ischemic cardiomyopathy. We could say ischemic cardiomyopathy if that's present, i.e., wall motion abnormalities, perfusion defects. In that case, see pages 6 through 7, post-MI complications. That was covered in a previous video. If it's positive for ischemic cardiomyopathy, then we have to do a coronary angiography plus or minus PCI, which is a percutaneous coronary intervention, I believe. So otherwise, let's say, for example, it's a non-ischemic cardiomyopathy. If it's that, well, you see pages 18 to 24 for cardiomyopathy. What if we had a younger patient and a family history of sudden cardiac death? And in that case, you do an EKG, QTC, which is QTC, whatever. EKG, QTC, medication reconciliation. So QTC prolonging agents, antiarrhythmics, amiodarone, sotalol, fluoroquinolones, chlorothiamycin, erythromycin, ketoconazole, amitriptyline, antipsychotics, haloperidol, quetiapine, or I think it's I say quetiapine, but I think it's quetiapine. I don't know. It's either quetiapine or quetiapine. Antiemetics, ondansetron, metoclopramide, methadone. QTC greater than 500 ms on repeat 12-lead EKG / short QTC syndrome, less than 340 milliseconds. In which case, long or short QT syndrome. What about if it's ST segment concave on V1 through V3? In that case, it's Brugada syndrome. What if it's J point elevation, in which case it's early repolarization syndrome? In all three cases, ICD placement if syncope or ventricular arrhythmia. So I guess the end point for all of these things is just kind of slowly, not everything, but a lot of them lead to this final end result of ICD placement if the syncope or ventricular arrhythmia. So what is so ICD placement is implantable cardioverter defibrillator. Okay, so implantable cardioverter defibrillator, ICD placement. So let's continue with some explanation. Ventricular tachyarrhythmias. Ventricular tachycardia, VT. A 66-year-old male with a past medical history of type 2 diabetes, tobacco use disorder, non-ischemic cardiomyopathy, and heart failure with reduced ejection fraction, or EF of 25%, presents with a palpitations and lightheadedness. Exam has a heart rate of 180, blood pressure of 90/65, SpO2 of 92% on room air. Labs and imaging show EKG with a wide complex tachycardia with no discernible P waves, troponin mildly elevated, hypomagnesemia, hypokalemia. Management, if sustained VTAC, or hemodynamically unstable, treat based on ACLS protocol, defibrillation, epinephrine, amiodarone. If it's non-sustained ventricular tachycardia, well then medications for non-sustained VT, beta blocker, antiarrhythmics like classes 1A, 1B, 2, and 3. Just look those up if you don't know what those are. I can't say that I know off the top of my head for a lot of those things, so I'm going to have to review that myself. If refractory to medications, catheter ablation. Evaluate for and treat reversible causes of arrhythmia, electrolyte imbalances, replete potassium, magnesium, myocardial ischemia, troponin, stress test versus coronary angiography, hypoxia, adverse drug effects, anemia. Consider ICD for secondary prevention. Complications, ventricular fibrillation, sudden cardiac death, cardiogenic shock. High yield fact. Torsades de Pointe. I can't say I says torsades, but torsades de Pointe or Pointe. Pointe. I don't know. Torsades is. I don't speak French. Torsades is a ventricular tachycardia with characteristic morphology of a twisting QRS and increasing and decreasing amplitude. It is usually triggered by a QTC prolongation, either due to medications, electrolyte abnormalities, or congenital long QT syndromes. It has a poor prognosis and is rapidly converts to ventricular fibrillation. Give magnesium and cardiovert if unstable. Do they have a picture of it? Yeah, they have it right here, torsades. So it looks kind of like that. It looks like streamers. It looks like, if you see in a DNA, picture of DNA, it looks vaguely like that because it's kind of this sort of, the way DNA looks like is that the DNA kind of, when you're looking at a 2D image of DNA, you could tell that it's like expanding and contracting because of how you're viewing it personally. But Torsades looks like that. It's like expands and contracts, expands and contracts. Anyway, ventricular fibrillation, or VFib. A 65-year-old male with a past medical history of type 2 diabetes, tobacco use disorder, and hypertension is brought by the EMS after he lost consciousness in supermarket and bystanders called 911. CPR was started. He was found to be in a shockable rhythm by AED and received 2 shocks before return to spontaneous circulation. Exam, blood pressure is 100/65, heart rate was 103, SpO2 of 92% on room air, diaphoretic. So he's sweating. Lab/imaging, rhythm strip on the field shows ventricular fibrillation and broke after 2 shocks. Current EKG shows normal sinus rhythm, troponin elevated. Management, ACLS protocol, which means defibrillation, epinephrine, and amiodarone. Once stabilized, evaluate for coronary artery disease, that is to say, left heart catheterization. Consider ICD, and again, ICD, we were talking about that before, is the implantable cardioverter defibrillator. So consider that for secondary prevention. Complications of ventricular fibrillation or VFib, sudden cardiac death, cardiogenic shock. High yield fact, EKG for ventricular fibrillation shows no P waves or QRS. The irregular deflections represent ventricular quivering, which may be fine or coarse. Okay, so here's Torsades. Right, looks like that streamer presentation. Here's the ventricular fibrillation after 6 beats. Sinus rhythm degenerates into ventricular fibrillation. And there's no P waves in it, as they were said before. And finally, here's a multifocal PVCs. 2nd, 6th, and 9th beats are PVCs. And so that's all kind of all over the place. These random beats that happen, and they are ventricular. You can see that it's number 1, number 2, number 3. You can see those are ventricular in nature because they have this very wide presentation. And they're kind of overlapping and covering up the normal rhythm that you see elsewhere. Make sense? So this is more stuff from the continuing part of the chapter. We're on page 36 right now. We'll go over to now 37. So this starts going in the drug stuff. This is kind of its own little thing. And I'll probably go into some other topic as well before we finish up the chapter. But this video has been going on for 54 minutes. We started on page, I think, 27, and we finished up on page 37. It's a little bit shorter of a video, of course. We got about 10 pages in an hour, or a little bit less than somewhat less than an hour. So we'll have about, if it's 37 pages now, and we have 13 pages to finish up or something like that, or 15 pages to finish up, I think I can deal with that. So anyways, hopefully this was of use to you. Have a great rest of your day. Thank you, and goodbye.